Welcome everyone to the eMedica MRCGP AKT High Yield Revision Webinar 3 for the January 2023 exam. Today is about high yield revision to prepare you for your exam. We're going to go through 15 exam style questions, followed by rapid reviews and examples. I'm going to split it into sort of 3 parts. So the first part, we'll do 5 interactive questions where I'll show you a question for 55 seconds, give you a chance to answer it. Then we'll go through the answers, explanations, and teaching. Part 2, we're going to do a timed mini mock exam, just to get you used to the optimum pacing and get you used to answering questions from different subjects all thrown at you one after the other. So we'll do a 10-question mini mock, and then we'll go through the answers all in one go. Then part 3, we'll talk about what to do to make the most of this important period between now and the exam. We've got about 6 weeks to the exam. So let's get underway. So we're going to go straight into the first 5 questions. I'll show you a question like this, 55 seconds, and then we'll go through answer and explanation. Here we go. So the popular answers are A and C. Okay, A and C are the popular ones. So the correct answer is A, that the hearing in the right ear is mostly in the normal range. Now you notice here the ears aren't labeled. That's part of the test. Audiograms that are in color have a standard denotion. The right ear is always red, refer right. And therefore the left ear will always be in blue. So you can see this is the right ear. And can you see that pretty much all the way across it's in the normal range? You've got just a tiny bit of loss right at the top of the scale here, okay? But that's very, very mild. So mostly in the right ear, it's in the normal range. Do you see that's the correct answer? Now, the second most popular answer was C, that this is consistent with a conductive hearing loss in the left ear, okay? Now, this is the left ear, and there's a loss here, but we can't say that there's a conductive loss. Why? Because for that, there'd have to be a difference between the air conduction, which is what we're seeing here, and the bone conduction. Bone conduction is shown in brackets. Now, you see there is no bone conduction shown in this audiogram. That's because when it says sensory neural hearing loss, typically they don't bother showing the bone conduction. In a conductive loss, you'll see the bone conduction, but bone conduction is always brackets, not crosses and circles, okay? And so that's why C is not correct, all right? Option B, that hearing is in the left ear is mostly in the normal range. You can see in the left ear is almost entirely in showing hearing loss. In fact, moderate hearing loss, once we get above about here, that's moderate hearing loss. Okay, this is mild. There's not any of it that's in the normal range. Okay, and then option E, that both ears show mild hearing loss. No, this one's normal. The right ear is normal, basically. So that's why it's incorrect. So let's go through the different things in an audiogram. So look, this is what a conductive hearing loss would look like. You'd see the bone conduction in the normal range. Bone conduction always shown with brackets, either sort of squared brackets or triangular brackets like this, but always brackets. Sometimes you see one ear with square, one ear with triangle, as well as the different colors. Sometimes they'll both be squared brackets, but always brackets. So bone conductions in brackets. Air conductions either with a cross or a circle. So you can see both of these are air conduction. One for the right ear, the red one for the left ear. So what does this audiogram actually show? What are we seeing in this audiogram here? You're seeing that bone conduction in the right and the left ear is normal, and air conduction in the right and the left ear are reduced. This is an example of a bilateral conductive hearing loss, okay? And then in a sensory neural hearing loss, typically they won't bother showing the bone conduction, like in this one, okay? Or this one, no bone conduction shown. That's because we just care about the air conduction, all right? What does this pattern show? Well, you can see that both ears have a loss in the high frequency. Type into the chat, what would this be a typical picture of? What would be the diagnosis that would show this type of pattern of hearing loss? Bilateral with high frequencies reduced, but low frequencies actually in the normal range. Yeah, this is typical of presbyacusis, the hearing loss of old age. This is the most common type of sensory neural hearing loss. Okay, so if we go back to our image, this is normal, this is very mild loss, and then this is moderate loss down here. Do you see? So look, mild loss 20 to 40, normal is above here, and then once you're dropping 40 plus, that becomes moderate, 70 plus is severe, 90 plus is profound. Okay, right, question number 2, here we go. Okay, so I'll stop you there. Now, 3 popular answers, A, B, and D. Okay, now this is an example of a 2-step question. The mark is for management. That's the second step. The first step is working out the diagnosis. That could be the question in itself, right? So let's work on that as well. What do you think is the likely diagnosis here? And then I'm going to give you a follow-up once you've answered that question. Great, so the answers people are putting epididymo-orchitis or prostatitis, okay? So this actually fits with epididymo-orchitis. Well done, that's the most popular answer. So most of you have got that right. Okay, now I'll go through the right answer and then we'll look at which variant of that is, which is the follow-up. What do you think is the likely cause of this patient's epididymo-orchitis? Okay, so the correct answer in terms of management is D, treat with levofloxacin for 10 days. And well done, that was the most popular answer. Just under half of you got that right. So why not the option of B and the option of A? Well, this is where those of you that thought that you had a different diagnosis, that might be why you picked B or you picked A. So I'll come back and explain that in a minute. Let's look at, first of all, epididymo-orchitis. How does it present? And then what are the different things that could cause it? Okay, because that's going to link us to the answer. So first thing is that it tends to have a gradual onset. It's usually painful as described by the patient, and on examination will be tender. There'll be a palpable swelling. There's usually erythema overlying it. And one of the really useful tests is the PREN sign, or the PREN test. So that's where you elevate the scrotum and thereby elevate the testes, and it takes the pain away. That's PREN positive, which is what you'll typically see in epididymo-orchitis. Whereas if it was torsion, PREN will usually be negative. That's even if they let you elevate it, because torsion tends to be exquisitely tender, doesn't it? Okay, but the pain won't reduce when you elevate the scrotum in torsion. So it's one of the ways that it can be useful to separate. Okay, now, when would you, for epididymo-orchitis, admit someone? If they had really severe symptoms and, high fever, septic, systemically unwell. That's not very common. Okay, but if you had someone like that, you'd admit them because they might need IVs. Okay, ideally, if they're willing to go to GU medicine, we want to refer for them to be seen within 24 hours. If not, we can treat them in primary care, and we should treat them in primary care. And the treatment that you give depends on the likely cause. So there's 2 forms. You can either get this related to an STI, especially gonorrhea, in which case you'd give ceftriaxone plus doxycycline with or without azithromycin. Or you can get it because of enteric organisms, i.e. those who it could be related to a UTI, patients who are low risk for an STI variant. For them, either ofloxacin for 2 weeks or levofloxacin for 10 days. So let me just go through. You see, this patient, he recently had a UTI, not been sexually active for a month. You see, it's much more likely that this patient has the UTI variant, an enteric cause, than an STI variant, like gonorrhea. So you can see, when would you admit? Well, in the context of epididymo-orchitis, you might admit not for surgical management, but you might admit for IVs if they were septic. When would you admit for surgical management if you thought it was torsion? Younger patient, Pren negative, okay? When would you treat with ceftriaxone and doxycycline if you thought that the STI variant was the cause? So, if it recently been treated or recently had symptoms of an STI, if you had discharge or, and so on, okay? Those of you that picked C, this is a good learning. It's good to make this mistake here so you don't make it in the exam, of exam technique, that a lot of you will have just seen ofloxacin 200 milligrams, thought, oh yeah, that's the right dose and the right drug. You're absolutely right, but not as a single dose. It's a 2-week course if you're going to give ofloxacin. That's why this one's incorrect. It's this bit here. Reading each part carefully, really important, big part of exam technique. This was the correct answer, right dose, right time length. And then azithromycin 1 gram orally as a single dose, that doesn't fit here, okay? So let's move on to question number 3. Very topical, what with invasive group A streptococcus in the news and the unfortunate number of cases that have led to significant complications. Really important topic, right? So here we go. Okay, that's time. So 2 popular answers, A and B. No need or delayed script for Pen V. These are the 2 popular answers, okay? Followed by D, start Pen V today. That was the 3rd most popular answer. Okay, so now, again, this is a 2-step question, right? The question is about management according to the FeverPAIN criteria. You see, step 1 is working out the FeverPAIN score. What do you think is this patient's FeverPAIN score? Okay, so we've got a range from 1 to 4. Okay, the different scores that people are putting, and that might explain the answer, because if you thought it's 1, your approach to management is going to be different to if you thought it was 3, which might be different to if you thought it's 4. Okay, so this patient's FeverPAIN score is actually 3. Let's go through why that is, and because of that, the right answer is B, offer a delayed script for Pen V. Okay, do you notice it doesn't mention any allergy, and so you go with the first line, which is Pen V. What's the normal length of treatment with Pen V in this situation? Because it's different for clarithromycin or erythromycin. Yeah, great. 10 days for Pen V, 5 days for clarithromycin, erythromycin. Okay, right. So let's look at why the FeverPAIN score is 3 in this patient. So look, they're presented within 3 days. That's the A in FeverPAIN, is attending rapidly within 3 days. They attended within 2 days, so they get 1 point for that. Okay. They had a fever early in the day, even though their afebrile examination reported fever within the last 24 hours is enough to get a point. So they get a point for that, the fact that they had a fever earlier in the day. And then that's the fever part of FeverPAIN, right? Okay. And then the fact that the tonsils are inflamed, that's the I. They get a point for that. That's 3. Okay. Do you see? They don't get a point for the N, the no cough or coryza, because they have got runny nose. So they've got coryzal symptoms. Therefore, they don't get any points for that. You'd have to have no cough and no coryza. If you've got either one of them, you don't get a point. Okay. So they don't get any points for the N. And the P is purulent, right? Pus. There's no pus. So they don't get a point for that either. All right. Do you see? So that's why the score is 3. So that's FeverPAIN. You get 1 for each of the following. All right. So fever within the last 24 hours, and that includes reported fever. So, they recorded it. The parents tell you they had a fever. Even if they're afebrile now, if they measured it within the last 24 hours and it was high, you get a point for that. P is purulent, so pus on the tonsils. Okay. Pus on the back of the throat. A is attending rapidly, so 3 days or less from onset. This patient was 2 days, wasn't it? I is inflamed tonsil. So even if there's no pus, it's inflamed, you get a point for that, all right? And N is not having cough or coryza. If they've got either one of them, they don't get a point. So if they've got cough or if they've got runny nose, cold-like symptoms, they don't get a point for the N. So if they score 0 to 1, the likelihood of this being bacterial and needing antibiotics is really, really low. So we don't give antibiotics. If they score 2 to 3, there's actually a decent probability that it could be bacterial, which is why you'd consider a delayed script. Whereas 4 to 5, there's a high probability that it's bacterial, and you should consider starting antibiotics that day. And then what antibiotics? As long as they've got no allergies, first line is Pen-V for 10 days. If they had a penicillin allergy, then clarithromycin or erythromycin, which are both just for 5 days, but that's because of the allergy, okay, that you can't give Pen-V in that situation, okay? Right, question number 4, here we go. Okay, great. Now, this is a revision for some of you that have been to our main full day course. For others of you, you might not have covered this topic, so it's a good, learning for it, okay? So the key thing here is that the access to health records, the records that they want to access is not their own. The patient wants to access their father's records who's passed away, and they're the next of kin, as well as the executor of the will. So, they've got a legitimate reason because they're concerned that there might be negligence. So the correct act for that is the Access to Health Records Act 1990. So E is the correct answer. I'm really pleased to see that most of you got that right. Okay, quite a few of you, the second most popular answer was C, the Data Protection Act. You can use this act if you want to access your own records, your own information. You couldn't use this to access someone else's. You can see they want to access their father's record who's passed away, not their own. Okay, so key bits of legislation that you want to know about in relation to health records. So the Data Protection Act 2018 is what you use if you want to access your own information. Currently, you could also use GDPR, the General Data Protection Regulation, which is actually a European law, but it's still in place, okay? The Data Protection Act was updated in 2018 in anticipation of Brexit. The Access to Medical Reports Act 1988 is where companies want to access information on their employees, usually when it's to do with occupational health reasons. And then the Access to Health Records Act 1990 is if someone wants to access records of someone who's passed away, but they have to have a legitimate reason to do so, i.e. they're the next of kin or the executor of the will, and you have to state why you want to access it. Maybe, like in this case, you're worried that there might be some negligence. Okay. Right, data interpretation, here we go. Right, okay, so really happy to see most people have got this one right. So the key thing here is that we're looking for the worst mortality rate for women under 75. So if you look at the data here, this is mortality rate for all causes. See, that's the same as mortality rate, okay? But as you can see, this is mortality rate from all cardiovascular disease, i.e. this is just cardiovascular mortality. Do you see, all of these deaths are also going to be included in this, because this is mortality for any cause: cardiovascular, cancer, someone died in a road traffic accident. They're all going to be listed under here, the all-cause mortality, whereas this is just someone that died because of cardiovascular disease. So we ignore all of this. From these three, this is about women under 75. So we want to make sure we're looking at the right line, which is this one: under 75 mortality rate from all causes, female. So we just want to look along this line. And the worst rate is the highest number of deaths per thousand, isn't it? Okay, so you want the highest number along this line, which is 324, which is Doncaster, right? So the correct answer is D, Doncaster. And, you know, I was really pleased to see most of you got that right. The second most popular answer, quite a few of you picked B. Okay, B being Bradford. So why might you have done that? Well, if you look at female just for cardiovascular deaths, not all cause mortality, just cardiovascular, okay, then you'll see that Bradford, 65.6 deaths per thousand, had a worst rate compared to Doncaster. So did Barnsley, had a worse rate, but I can see why people might have picked that. Similarly, if you looked at persons, men and women, and you didn't read this part carefully, that it just said women under 75, persons means male and female, okay? If you looked here, again, Bradford had the worst rate, okay? So that's why you might have picked that, is that you missed this bit and you're just looking on the wrong line. Now, this is one of the new style data interpretation using real life public health data. See, there's no calculation here. But if you can get familiar with this type of, it just makes it easier to read this carefully and pick up what should I be looking for, okay? And then other kinds of data that could come up increasingly in the last few years: prescribing data, regional disease incidence and prevalence, you know, other types of public health data. Within mortality rates, you might look at infant mortality, and then interpreting graphs and charts from research. So I'll give you some examples, and we cover these graphs in our main stats webinar, which is happening this weekend. So this is, for example, demographic data, different age groups in a particular surgery. Again, this is real life data. Actually, this data is taken from a practice where I've worked on and off since I became a qualified GP. This is prescribing data, again, from a real practice in London. This is called a quinary graph. So this is looking at age profiles in 5-year bands. Okay, again, real life data. And then this is infant mortality rates. And then understanding research. So this is a Cape's plot looking at people that had certain treatments, what their outcomes were. And this is a leaf plot looking at pre and post-test probabilities based on, this particular one was based on COVID-19 tests, RT-PCR. Okay, we'll cover all of these at the stats webinar this weekend. Right, any questions, put them in the Q&A, but just let me let you know about the masterclass webinars. So these are live webinars. We do have recordings available for people that aren't available on the days, but we do learning like we've just done, where we do a question in time conditions, then we do the rapid review of both that topic, but specific keywords and technique, why you might have got it right or wrong. We'll do that one question at a time for 45 questions in each webinar. But sometimes we'll do one question, but we might talk about 4 or 5 topics. So although there's 45 questions in each webinar, we'll cover 60 plus topics, okay? So it's really interactive. So stats is 4 hours. The next one is this Saturday morning, 9:30 to 1:30. Admin, 4 hours, also on Saturday, 2:30 to 6:30. And then we have High Yield Clinical Grammar 1 and 2, which is 7 hours spread over 2 evenings, the 21st and 22nd of December. So we'll do 7 p.m. to 10:30 each time. So, you know, between them all, we'll cover over 200 topics. If you book all of them, you get a huge discount. So the stats and admin are £125 each. This is £198 for the 2 days. But if you book all 4 as a bundle, it's £299 rather than £448. So you save nearly £150. There are recorded versions available if you're not free on the day. If you do attend on the day, you can get access to the recording afterwards for a month. Those of you on the Pass Guarantee program, you're already booked for all of these, and you'll have access to the recordings automatically in your resource page afterwards. Okay, so stats is Saturday morning, admin is Saturday afternoon, and then High Yield Clinical 1 and 2, 21st, 22nd in the evening. Okay, right, let's do the timed minimum. We're going to do 10 questions. Every 55 seconds, the questions will move forward automatically. Write down the question number and the letter that is your answer on a piece of paper at home. You won't see me until we've done all 10, then we'll go through the answers and explanations. So I just want you to get used to seeing multiple questions one after the other and get used to managing your time. Here we go. Right, well done, everyone. So I'm going to show you the questions one at a time, okay? And if you just select your answer, you've already written these down, haven't you? Okay, so I'll give you just a few seconds to select the answer. So the key thing here is that this patient's on 120 milligrams twice daily of modified release morphine. Okay, that's really important. So the two popular answers are C and E. The correct answer is C. Well done. 2/3 of you have got that right. So why is it important to look at the total dose? Because when you're converting from any opioid to another, oral morphine is the universal opioid. So you look at the equivalent of oral morphine, and then you do your conversion. So look, they're on oral morphine 120 twice daily, i.e. 240. Now we're going to change them to a syringe driver with diamorphine in. So you just need to know the conversion. That's the knowledge part that's being tested, right? Okay. The technique part is reading carefully and picking up that it's 120 twice daily, because sometimes people miss this and they just think, oh, they're on 120, and they divide based on that. The knowledge part, if you know that converting from oral morphine to diamorphine, it's 3 times stronger diamorphine. So you divide by 3. So 240 divided by 3 is 80. So just go through that calculation again. 120 milligrams oral morphine twice daily is 240 milligrams of total oral morphine. When you're converting that to a syringe driver with diamorphine in, you divide by 3. So 240 divided by 3 is 80 milligrams subcut. You put that in the syringe driver as a 24-hour infusion, and that will give you the equivalent amount. So those that picked E, 120 over 24 hours, that's too much for diamorphine. That would be the right conversion if you were changing from oral morphine to morphine in a syringe driver. You can put morphine in a syringe driver, okay? Because morphine by injection is twice as strong as morphine orally, whereas diamorphine is 3 times, okay? So if you're going to put someone on a syringe driver, how do you calculate the dose to start them on? You then can tweak it based on how they respond, but you calculate their current 24-hour oral morphine, and that includes any breakthrough doses. And then if you're going to convert to morphine by injection, just divide by 2. If you're going to convert to diamorphine by injection, just divide by 3. So, for example, if they were on 60 twice daily, so 120 in total, then for morphine, that would be 60 because you're divided by 2. For diamorphine, it'd be 40 because you're dividing by 3. This patient was here, right? 240 in total, 120 twice daily. So you divide that by 3 for diamorphine, that's 80. For morphine, it'd be 120, and so on. Okay. All right. And then this one, key thing here is that both parents, or potential parents, because they're considering family planning, and it's good that they're thinking ahead, right? But they're both carriers for hemochromatosis. So the first thing is to sort of have the knowledge base that hemochromatosis is autosomal recessive. Okay. The second bit is technique, reading the question carefully. They're asking what's the risk of their children having the disease, not being carriers, but having the disease. You see, okay? And so the correct answer is C, 25%, okay? The second one in the set was asking what's the risk that their children become carriers, just like they are. So they're both carriers. What's the risk that children become carriers? The risk is 50%, okay? And nearly everyone got this one right. So if we go through the genetics of autosomal recessive disorders. So hemochromatosis, you can see, if they're both carriers, you've got a hemochromatosis gene and N is the normal gene. So carriers, they've got one abnormal gene, the H, one normal gene, the N, right? You get one from your mum, one from your dad, right? There's a 1 in 4 chance that you're unlucky and you get H from mum and H from dad. This person will have full-blown disease. You see, that's a 25% chance. There's a 50-50 chance that you get the H gene either from mum or dad and get the normal one from the other one. Either way, you're a carrier. You might have some mild symptoms and you could pass it on. And then there's a 1 in 4 chance that you're fortunate and you get N from mum and N from dad. Not only do you not have any symptoms, you can't pass it on to the next generation. Okay, you're not even a carrier. All right, and that's how autosomal recessive inheritance works, right? So if both parents are carriers, there's a 50% chance that you become a carrier yourself. There's a 25% chance that you have full-blown disease, and a 25% chance that you're a healthy non-carrier. So alongside that, it's worth learning the modes of inheritance of the key diseases for the UK population. Okay, and these are the relatively more common, or more important. For example, things like CF and PKU, we screen for in the UK, right? Right, question number 9. This is an example of a multiple best answer, right? And what makes it even more challenging, it's also an example of a negatively framed question. It's the first one we've done today that's negatively framed. That's because most questions in the AKT are positively framed. What's the likely diagnosis? What's the right management? What would you test? What would you give? Okay. But you do get some questions like this one, where I can say this is asking, which of these would you not do? Which would not be recommended as part of the diagnostic workup for this particular patient? Okay. All right. Now, this bit wasn't in your question, the diagnosis. I've added this here for now, right? Okay. Type into the chat, what do you think the diagnosis might be? What is it that we might be looking for? Because that's going to help you to work out the tests, okay? And then the other thing that makes it challenging is multiple best answers are marked in the AKT in a harsh way. You have to get both right to get a mark. If you get one right and one wrong, you will get no marks. There are no half marks in the AKT at all, okay? It's not possible to get half a mark. You either get it fully right, you get a mark. You get it partially right, you get nothing, all right? So with these symptoms, she's having periods, 6 to 8 weeks for most of the year, all right? So first of all, that says there's some variability. But look, then she had a period, no periods at all, 3 months. Then it started back again. And then she's also got some of the symptoms that you might see in someone who is around the menopause, okay? Changes in mood, things like that, okay? So the correct answers are A and H, okay? So this fits with premature ovarian insufficiency, all right? That's what we'll be thinking about. And, she's under 40, isn't she, okay? And the two that you would not be recommended as part of a diagnostic workup, a pelvic examination and AMH. Now, nearly all of you picked AMH, and it might be because you've never ordered one. And actually, that's not a bad way. Like if you're asked to pick something you wouldn't do and you've never heard of something or you've never done it, probably not something that you do a lot. That's actually, if you've got no clue, that's not a bad way to pick something, okay? But about only a quarter of you picked A as your second option. So very few people got a mark for this, because most people, while you got this, you picked one of these ones as your second one, so you get no marks. There are no half marks, okay? Just highlights the sort of challenge in multiple best answer questions, okay? So this is straight from the guideline that, first of all, when would we suspect premature ovarian insufficiency? Basically, if they're under 40 and they're not on the pill and they've got menopausal type symptoms, so that could include periods that are infrequent, elongated, having periods, no periods at all, then it comes back again, raised FSH, so 30 international units per liter or more on 2 samples, taken at least a month or between a month and 6 weeks apart. And then other things that you might do, LH, estradiol, prolactin, TSH, testosterone, but the guideline specifically says that you should not routinely perform a pelvic examination or use AMH testing as part of diagnosing this, okay? That's why they're the right answer. But you see the challenge, you need both to get the mark, all right? Okay, question number 10. So this is to do with GMC guidance. So this is part of the admin domain, okay? And again, it's a multiple best answer. So which 2 of these are correct? You've been offered a gift voucher, having been involved in the care of someone's last illness, towards the end. So the correct answers, again, you need both to get the mark, are B and F. So unsolicited gifts from patients or relatives may be accepted in some situations. We'll talk about which. And the GMC doesn't set any maximum value, all right? Interestingly, a lot of people got this right, but didn't pick F, picked E as your second one. Gifts with the value of £100 or more need to be reported. And why might you have got that wrong? This, again, another powerful sort of learning. It's good to make these mistakes here with us so you don't do it in the exam. And that is that, let me know in the chat, how many of you read this as GMS, which is one of the types of NHS contract. There are 4 NHS contracts, right? GMS, PMS, APMS, PCLMS, all right? How many of you read this as GMS? Because in the GMS contract, it does have a clause about gifts with a value of £100, but this question's about GMC guidance, not the GMS contract. The GMC doesn't specify any maximum value, okay? You see, again, reading carefully the question, really important bit of technique. So the GMC talks about when we can and cannot accept gifts. It doesn't give any value, Okay, so we're not allowed to encourage gifts or pressure people to make donations. We're not allowed to alter the management or the services that we offer to a patient or their family based on gifts, because then it's a bribe. And you shouldn't accept a gift if it might be seen as you're taking advantage of someone. But as long as none of those apply and they give it freely, an unsolicited gift can be accepted. And especially this time of year, those of you in practice, you'll see it's quite common that patients will drop off gifts for, some of the partners. Okay, you might get some as a registrar, but it's a lot more common for the partners because often they've known them for many years. All right, you might have only been there a few months. All right, see, that's what the GMC says. They don't state any maximum value. All right, those GPs that work in a practice that holds a GMS contract, GMS is General Medical Services. It's the most common NHS GP contract. Okay, that's got nothing to do with the GMC. They have a clause in that contract that gifts worth £100 or more must be recorded in the register of gifts because they're considered high value gifts. That's nothing to do with the GMC. So you see the importance of reading the question carefully as well as knowing the guidance. Okay. Question number 11, clinical. So rheumatoid. The correct answer here is A, refer within 3 working days. You don't wait for the blood test results. Again, very few people got this right. A lot of people thought it was going to be within 1 week if the tests were raised. A lot of people picked wait for the tests and refer routinely. Okay. So what are the key features in this patient that qualify them for this 3 working day, i.e. a very urgent referral? What are the features for this particular patient? Yeah, it's the fact that it's affecting the small joints of the hands and feet. Okay, that's the key. That's one of the criteria for a very urgent referral. By the way, anyone with suspected rheumatoid should get a referral within 3 weeks. But those that have got additional high-risk features should be within 3 working days. So anyone with suspected RA, within 3 weeks, they should be seeing a rheumatologist. Who to refer ultra urgently within 3 working days? Any one of these 3 criteria. The small joints of the hands or feet are affected. That's this patient. More than one joint affected. Or they've already had symptoms for at least 3 months, i.e. by that stage, can you see the disease is already progressing. You want them to be seen very quickly so that they can get onto disease-modifying anti-rheumatic drugs. And the guidance says that you should not delay referring while you wait for blood tests. You'd still do the blood test, but you should still get that referral going, because if you wait for blood tests, that's going to delay them getting treatment. Okay. Number 12. So alcohol, again, an area that people often struggle with. So good to revise it. Okay, great. Most people got the right answer right. Correct answer is D, 27 units. Now, there's 2 ways you could do this. One is if you know that a large glass, 250 ml glass of wine usually has about 3 units in it, okay, at a moderate strength. This is a moderate strength wine, okay? Then you could just do it in your head. But there is a little bit of technique here in reading carefully. How many glasses of wine does this patient have in a week? Well, they have 7 nights a week, they have 1 glass. But on Saturday and Sunday, maybe because they're not working, because they're a teacher, okay, they have another one at lunch. So you can see in total they have 9 glasses. So 9 times 3 is 27. You could do that in your head. The other way you do it is to use the formula. So units is volume in milliliters, so 250 milliliters, times by the percentage alcohol by volume, 12%. Take that total, divide it by 1,000. That gives you how many units. So if we did that, we'd get 3. And then times that by the number of glasses. Again, that's 9, 27. So why might some of you have got a different number? Why might some of you have got 21, which was the second most popular answer? Because you might have just seen this 7 and not read that on Saturday and Sunday she has another glass at lunch. You see the technique there, reading carefully the scenario, okay? So this is how many units of alcohol are in common types of drinks. So wine at 12%, a small glass, 125 mils, about 1.5 units. Large glass, 250 mils, 3 units. Now, some wine will be a bit weaker, some will be a bit stronger. All right. Beer, standard strength's about 3.5%, 4%. A pint's about 2 units. Premium or stronger beers and lagers, 5 to 6%. Pints about 3 units. Spirits, 25 mils of any spirit at 40%, which is the common strength of most spirits in the UK, is 1 unit. And then cider is often quite strong, typically similar to premium beers and lagers. And so a pint's about 3 units. And then you've got the formula to do it accurately there as well. Okay, diabetes. So increasingly, GPs are the ones that are commencing patients onto insulin. All right. And so this has been tested, but also been highlighted by the examiners as something people find difficult. So patients, HbA1c, you can see 70, so not well controlled, despite they're on 1, 2, 3 different drugs. And so now we're going to put them onto insulin. Okay. So the correct answer is B. Keep them on metformin. You could stop these ones. And then you put them on NPH, neutral protamine hagedorn. Okay. Now, the most popular answer was D, to start insulin detamir and continue the metformin. We'll look at why that's not the right answer in a minute. Okay. And part of that is to do with his control. So anyone know what type of insulin is NPH? Is it short acting? Is it long acting? Is it intermediate acting? So NPH is intermediate. Okay, so NPH insulin, all right, as I said, intermediate to long acting insulin. You can either give it as a once daily basal regime, so they're staying on their metformin anyway, and then you have this as a baseline to just give a low level of insulin, or you can give it as a twice daily regime. If you give it once daily, usually you would give this in the evening, sort of, nighttime, and then it's going to give them slow release throughout the day. Okay. You continue the metformin usually. You might review the others. Like some patients, if their control was really bad, you might consider keeping another one. But generally, you keep them on the metformin and put them onto NPH. When would you consider going straight to 2 types of insulin, NPH plus a short-acting insulin? Is if the HbA1c was 75 millimoles plus, his was 70. When would you consider detamir or glargine instead of NPH? If they need help with injections, or if they've got lots of hypos and they're symptomatic with it. That didn't apply to this patient. And then it's important that we monitor blood sugars if someone's on insulin, because if their control isn't great, we might then change to add in. So you might keep them on this. You might add in a short-acting dose before some meals or all meals, depending on how bad there is. Okay, next question was a free text question. Remember, it was about the incidence of COVID-19 per million. So in a free text question, there's no options to guess from A, B, C, D. You type your answers. So we've got numbers ranging from 1.14 is the lowest I've seen to 41,560 is the highest I've seen so far. And in between, we've got lots. We've got 0.04, we've got 24, we've got 4.15, we've got 330, we've got 4,156, we've got 4.98, we've got 4.15, big range. Okay, so the correct answer is 41,560. Now, do you see the question said, type your answer to the nearest whole number? Now, if you put 41,560, you'd type this with your keyboard in the actual exam. If you type this without the comma, that would be fine. But if you put 41.5, you see, that's not to the nearest whole number. It's incorrect. If you, and you see, it says to the nearest whole number. It doesn't say to the percentage. Okay, it's asking for the incidence of COVID-19 per million. Why is it asking per million? That's the standard way that incidence of COVID-19 has been reported throughout the pandemic, because that's what the WHO uses. And so, all the countries, when they're reporting their COVID-19 incidence, that's the units they use. Incidence per million people in the population, do you see? And so some of you, what you did was you actually calculated a percentage, but that's not what the question asked. It's a good example where you can have knowledge but misread or misunderstand what the examiner is asking and still lose the mark. Okay, so what's incidence, first of all? Incidence is just the number of new cases out of the total population. So you see, the incidence is this. We've given the total population here. The number of deaths is irrelevant. Those of you that use this as part of the calculation would have got completely the wrong number. If the question asks, what is the COVID-19 related mortality, then you care about this number, right? That's deaths, that's mortality. See, this question's asking about incidence. So incidence is number of new cases, so 2,770,000, divided by the whole population. That's 66,650,000. These are actual numbers taken from Public Health England, okay? So that gives you this number. Now, some of you, this is what you put. Some of you, what you did, you then multiplied this by 100, and that would have got you 4.15%. The question didn't ask the percentage. It asked per million. Okay, so to get this per million, you need to multiply this number by 1,000,000. Like if you need to get it by 1,000, you'd multiply by 1,000. If you want percent just means per 100. That's why you're multiplying by 100 to turn something into percent. You see, it's always per something, isn't it? Here it's per million, so you multiply by 1,000,000. That's 41,560.39. Now, do you see, as the number after the dot, this first number is 3, if it's 4 or lower, then to the nearest whole number is 41,560. You can see if this was 5 or higher, then you'd round up to 41,561. So the correct answer is 41,560. Okay, so incidence is the rate of new cases of a disease. In some cases, it will be reported as a percentage, but it's very commonly reported as a proportion of the population. Both are correct, but this question asked for per million. Do you see? So only that would give you the mark. And usually you report it over a time period, in a year, for example. Okay, so 1% per year means 1 per 100, because percent just means per 100. All right, 2 per 100,000 is the same as 0.002%. Okay, so if you want to calculate as per 100, after you take the new cases and divide by the population, in the last step you multiply by whatever it's per. Percent means per 100, so you multiply by 100. If you want by per 100,000, multiply by 100,000 in that last step. In this case, per million, multiply by 1,000,000 in the last step. If you wanted per 1,000, multiply by 1,000, and so on. Okay, and then the last one, really happy to say nearly everyone's got this right. So the least suitable analgesic regime, if someone's on diazepam, which they're taking because as part of their detox program, okay, they're coming off heroin, is codeine. And why is that? Because benzodiazepines and opioids can cause respiratory depression, respiratory arrest, death. Okay, so recent MHRA alert. There are often questions on MHRA. MHRA is the Medicines and Healthcare Regulations Agency. Okay, so that you should avoid prescribing opioids in combination with benzodiazepines. If it's absolutely necessary, give the lowest dose for the shortest duration, and you need to really, make sure that we're keeping an eye on that patient. Let someone else know, what kind of things to watch out for. Okay, right. So add up your score. We get a total out of 15. So we did 5 questions before the mini mock, right? And then we did 10 in the mini mock, and total up your score. If you've got 11 or more, that would be a pass. All right. If you've got 10, that would be borderline. In some exams, it will be just below the pass mark, because 10 out of 15 is 66.6, right? So, in most cases, the pass mark's higher than that. Just once or twice, it was 66, and once it was 66.5. Okay. 9 or less, don't worry. You're not sitting the exam tomorrow. Okay. You've got a good amount of time. Hopefully you've identified maybe some bits in the curriculum you need to work on, but more importantly, by going through these are hard questions that we've done, okay? But we've done them so we can focus on the technique. Hopefully you see the importance of paying attention to keywords, how missing one thing can make a difference, okay? How you can have the knowledge but misunderstand the question, all right? So don't worry, use this as a spur to say, right, I've identified some gaps, but also now I'm going to really pay attention to reading the question carefully, that actually I mustn't jump to conclusions. I mustn't rush. That's all important. So in terms of revision planning, how to make the most of the last 6 weeks, by this stage, you should have already covered a good chunk of the curriculum. What you want to do is systematically cover any gaps or weaker areas. And then the last couple of weeks, you want to revise all your key stats, all your key admin, and all the high yield clinical topics that examiners have mentioned. The last 30 days before the exam, every day, I will post a video into the eMedica Facebook group for GP training support, where we'll do a question, some clinical, some stats, some admin, followed by a rapid review. All right, do those. Work on exam technique by continue to practice your online questions, but also doing some timed mocks. So those of you on our Pass Guarantee program, we're going to cover all the stats, admin, and high yield clinical anyway in these webinars that are coming up. You're automatically going to get these if you're in the program. For those not on the program, you can access them from the Facebook group. Someone will post the link. And then we're going to do a whole load of mocks coming up to the exam anyway. If you're not sure which bits of the curriculum you haven't covered, do download our AKT curriculum checklist, where we've taken like the 600 topics from the curriculum that you need to really cover and actually made it into a checklist. You can print this off. It's available as a PDF. We'll send it to you in the post-course links. And then make sure you've covered all the high yield topics. So a high yield topic checklist, again, in the post-course links, there'll be a link to it. Those of you that were at the course on the weekend, this was already in the post-course links that we sent out after the course, okay? So, this isn't all of them. There's more than this, but just tick these off. These are things that come up again and again and again. All of these have been mentioned by examiners. They're telling you we're going to put these things in the exam. Now, at this stage, you might not have time to read full-length NICE guidelines. If there's one specific one you want to read out, NICE CKS is a condensed version. They summarize. NICE CKS don't publish their own guidelines. They summarize NICE guidelines. So if you want to look up something specific, do that. If you want to cover lots quickly, you might find our case cards helpful. Again, those on the program, you already have this, and you also have access to the digital version, okay, which has recently been updated. For those that don't already have them, you can't buy the print version anymore for 2022. They've sold out. The 2023 cards will be published at the beginning of January. If you pre-order, you can get a discount. You'll see it here, and we will post them out like the very first day after the bank holiday in January. There is a bundle where you can get both the printed card as a pre-order and then the digital cards as instant access, or you can just get the digital ones if you want to start revising now and don't feel that you need the printed ones. Okay, so they get updated twice a year, so they're up to date, including things like this, which were recently updated. And then if you found the way that we learned by doing that 10-question mock, if you found that helpful, on the 7th of January, we have our AKT 200 mock crammer, where we will learn by doing 4 50-question teaching mocks like that. So you'll do 50 questions in a go, and then we'll do rapid reviews, and you get a topic review, and we'll go through the guidelines for 50 questions. Then you'll have a break, then we'll do another 50, then lunch, and so on. By the end of the day, we will have reviewed 200 plus topics, and they're in the same proportion. Each mini mock is in the same proportion as the real exam. 80% of the questions are clinical, 10% are stats, 10% are admin, okay? And then you get access to another full 200-question mock afterwards. Again, those of you on the Pass Guarantee program, you're already registered for this, all right? It's a long day, 9:15 to 6:35. Just to recap, for those that aren't on the program, because if you're on the program, you already have access to all of this, okay? You'll already be registered for it. But essentially, the 3 things that are going to help you for the January exam, you could get our AKT Pass Plus online bundle, which includes basically the recordings of the full day AKT course that happened on the weekend. That's just been updated today. The AKT 200-question mock crammer, the stats and admin, which is this weekend, the recording of that, the High Yield clinical. You also get access to our question bank, which have got over 2,500 questions, including the mocks, and you get access to 3 full mocks. All right. Compared to buying them all separately, it's nearly £300 saving. For those that perhaps don't feel that you need the full day course that we had this weekend, the booster bundle is the AKT 200-question crammer course on the 7th of January, plus the 4 webinars, plus 1 full mock exam. That's 25 hours worth of learning. And it's about £200 saving on the bundle compared to getting them separately. And then for those that don't want the AKT 200-question crammer course and mock that comes with it afterwards, if you just want the webinar, so that's stats and admin this weekend and High Yield Clinical 1 and 2 the following week, that's 12 plus hours, and you can access the recording afterwards. That's $299. Again, nearly £150 discount compared to buying those separately. Okay, so I just want to summarize and say, look, this next 6 weeks is the most critical part of your preparation. I know you've already been working really hard, but you're going to see now, this is where a lot of things are going to start coming together. Okay, for those in the Pass Guarantee program, you're going to start doing your targeted revision plans specific to the areas that our data has shown you need the most work on. Then you'll see we've got all of this teaching coming, and by the time we've done all of that, your knowledge and your technique are going to get to where it needs to be. And then by the time we've done all the mocks, that will hone your technique, get used to managing your time, fine-tune you, and then come to the exam, you're going to be ready. You'll be prepared, you will succeed. And really, that's what I want to leave you with from Muhammad Ali, that when we're this close to the exam, it's really important that you don't count the days, but you make the days count. Every single day between now and the exam, make sure that you're doing something to progress your learning, that you're doing your questions, you're doing your reading, you're revising your case cards, you're practicing, you're reading over your notes that you've already made. You might have already summarized various things. Keep pushing, keep going, make every single day count, and you will see how much progress you make, because you're already being consistent. Now it's the time to add in intensity. And when you combine those things, consistent learning with a shot of intensity, you'll be unstoppable, and you'll come to the exam fully ready and you'll smash it. So thank you very much. All the best. Keep pushing, keep going. I hope you found this evening helpful, You're nearly there now. Make it count, and this last period is what's going to get you across that finish line. I'll see you soon. Thank you so much. Have a great evening.